For this patient that we're seeing with AML MRC over the age of 60, we certainly would be considering this patient for treatment with Vyxeos. And if we look at the FDA-approved label, this was approved for patients with AML MRC as defined by the WHO criteria. So again, those would be patients that we mentioned who had AML with 20% blasts with either antecedent hematologic malignancy, some kind of MDS defining cytogenetic abnormality, or multilineage dysplasia. And this was approved based on a phase 3 clinical trial that showed an improved overall survival for this specific niche of patients. As I mentioned, this drug was approved by the FDA based on randomized phase 3 clinical trial results. And again, I think when you look at the new drugs that have come to market for AML, it's important to realize that many of those were not approved on randomized phase 3 results, but phase 2 unrandomized clinical trial results. And so in this clinical trial, patients between the age of 60 and 75 were randomized to either Vyxeos or 7+3, which has been our standard for patients with AML for decades. And for patients who achieved a remission with Vyxeos, they proceeded on with Vyxeos consolidation. And in the 7+3 arm, patients who achieved a remission were eligible to continue on with 5+2 consolidation, which isn't necessarily our standard here in the United States, but is pretty typical in Europe, and I think for many of us is reasonable for a patient over the age of 60 for a variety of reasons. It was also preferred when we looked at the design of the trial to try to keep anthracycline exposure similar between the two arms. But the drug was approved because it led to an improved overall survival in this very challenging to treat patient population, with an improvement of the overall survival from 5.9 months in the 7+3 arm to 9.5 months in the Vyxeos treated arm. I think that when we look at these, when we look at this data, it can be easy to blow off this improvement in overall survival. It's a matter of 3 months. But the truth is that it took us 20 years to separate those two curves. And again, when we started this conversation, these patients are some of the most challenging to treat AML patients, and they have some of the worst prognosis. And so shifting that curve is certainly substantial. And the clinical benefit of achieving a CR is not only meaningful in terms of that patient surviving longer, maybe having the opportunity to proceed to stem cell transplant, but also frankly improving their quality of life and reducing their need for transfusions and other things. So this benefit in overall survival did not end in just overall survival for all patients, but if we look at patients who achieved a CR or CRI, those patients in the Vyxeos arm also had improved overall survival. And even when we incorporate transplant, patients treated with Vyxeos had an improved overall survival post-transplant. So in the 7+3 arm, the median overall survival was 11 months, and the Vyxeos arm did not have a median overall survival that's yet been met. So whether we look at patients who did not go to transplant and had a CR, and even those patients who proceeded to transplant, those patients also received a survival benefit. And this is certainly important, I think, especially if we think about taking a 65-year-old patient, putting them through induction chemotherapy, proceeding to a stem cell transplant. Certainly we want to know that those patients post-transplant are going to continue to do well, and that the relapse rate post-transplant and the survival post-transplant is hopefully improved for patients with a new drug like Vyxeos. And I think that these data are promising and are going to continue to mature.